Bismillah ar-Rahman ar-Rahim. Critically ill patients with respiratory disease. Patients often present critically ill to the emergency or the acute medical department with respiratory disease. This may be due to a deterioration or exacerbation of an existing condition and a first presentation of a previously undiagnosed disease or respiratory involvement of a systemic disease. As with any critically ill patient, standard management is required initially to stabilize with the focus, then moving to the diagnosis and treatment. Often those need to take place in parallel. Depending on the presence of any pre-existing respiratory disease and its nature and severity, it may be important to determine the disease, the specific treatment and or treatment limitations, and senior physician input should be sought for this. Initial assessment of critically ill patients with respiratory disease, including ABCD technique, which include airway, breathing, circulation, disability, and examination, then doing investigations. Airway. Is the patient maintaining their airway? If they're snoring or gurgling, we should ask that questions. Head tilt, chin lift, use suction if good views, and in any airway adjunct necessary, consider inserting guidal airway or nasopharyngeal airway if Glasgow Coma scale reduced below 8, and call intensive care unit if intubation and ICU care likely to be necessary, or if the patient is rapidly deteriorating or peri-arrest caring and full assessment has not yet been possible. The breathing. Cyanosis is there. We should search about cyanosis and what is the O2 saturation and if there is FiO2 available, and exclude tension pneumothorax clinically, measuring respiratory rate, doing blood gas, and giving oxygen or search about oxygen adequacy. If not, likely to need increased FiO2, or if this is already maximal, need ventilatory support and involve ICU. Is the CO poisoning? CO2 low. If CO2 low, if hyperventilating and already increased work of breathing to maintain O2 at current level may need to increase FiO2. If FiO2 already maximal, likely to need ventilatory assistance such as nasal high flow oxygen. If the CO2 is high, is the CO2 high, hyperventilating means hyperventilating patients, tiring or CO2 narcosis, such as what's happening in COPD. So consider ventilatory support. Request an urgent portable chest radiograph. The circulation, taking respiratory rate, blood pressure, cardiac monitoring, doing ACG, and measuring the fluid balance. status, ensure IV access secured and blood tests sent, look at blood pressure, jugular venous pressure, urine output, peripheral perfusion, such as capillary refilling time, and if the patient is hypotensive, we should assess the filling of veins, and we should consider fluids and if volemic or overfilled but hypotensive with poor urine output may need inotropic support, likely to need central venous access to enable central venous pressure monitoring, and this will aid drug administration. Disability, conscious level, Glasgow scale, or ABU, which means alert responsiveness to verbal commands, or responsive to pain, or unresponsive. Are they confused? Check blood glucose, temperature, pupils, signs of acute neurological disease, neck stiffness, such as plantar reflexes, and the tone of muscles should be assessed. The examination of the patient, temperature, sputum, astraxis, chest signs, pneumothorax, wheezy chest, silent chest, effusion, consolidation, pulmonary edema, cardiac murmurs, palpable abdominal organomegaly, skin and nail signs, skin rash, etc. Investigations. Immediate tests include whole blood count, clotting screen, C-reactive protein, urea and electrolytes, liver function tests, and blood cultures before antibiotics. The underlying cause of critically ill patients. If the known respiratory disease is there, this will enable more targeted therapy. Try and obtain recent medical history. Ask patients or their relatives about the disease severity, current treatment, plans of clinicians to plans of clinicians for long-term care such as immunosuppression, transplant list, home non-invasive ventilation (NIV), advanced directives, lasting power of attorney (ATC). What is the usual current health status, exercise tolerance, activities of daily living, and what has caused this deterioration, a potential reversible process, such as infection, drugs, pneumothorax, pulmonary embolus, or gradual progression of underlying disease. Review chest x-ray and compare with previous films if possible. For more if no known respiratory disease, a full history is required to obtain diagnosis. The patient's cardiorespiratory status and the illness severity will determine how brief and full this is. Ask about recent symptoms, travel, contact illness, risk factors for immunocompromise, usual health status, drugs. For presentation based differential diagnosis and initial investigations plans, we should read in a big textbook about breathlessness, chest pain, hemoptysis, immunocompromise, unexplained respiratory failure, diffuse lung disease, diffuse alveolar hemorrhage, pleural effusion, pregnancy, post-operative causes of respiratory problems, pneumonia, pulmonary embolism, pneumothorax, toxic agents, the upper airway disease, anaphylaxis, and so on. Treatment aims of critically ill patients with respiratory disease. In patients with non-severe respiratory disease with poor premorbid states, as for example very limited exercise capacity, comorbidities, severe dementia, intubation and invasive ventilation may not be appropriate. The patient may have their own views on this or have made a living will and advance directives. All notes should be reviewed, if possible, and this decision should be discussed with the respiratory consultant or the consultant on call. Non invasive ventilation may be appropriate. In patients with non respiratory disease with an acute exacerbation, infective or non infective, respiratory and organ support may be indicated to enable them to survive the episode. This should be discussed with the respiratory consultant or the consultant on call and ICU. If patients with no known respiratory disease, respiratory and organ support may well be indicated to enable them to survive the episode. This should be discussed with the consultant on call and ICU. If they have significant pre-existing morbidity from a non-respiratory disease, such as severe cardiac failure, severe dementia, the details of this should be ascertained and discussed with their usual consultant if possible. If there is any doubt about the patient's usual health status or no previous history or notes available, or they are deteriorating before full assessment can be made, full ventilatory and organ support should be considered. That's all, and thank you.